So I'm going to go straight to introducing Bassam, who was already introduced. But essentially, Bassam, he's a public health expert and based in Al-Quds University in Gaza. He has contributed to designing, implementing, and evaluating multi-year, multi-sectoral development-oriented programs in the field of psychosocial youth empowerment programs and strategic planning, and as well as many others. He's worked with us on various studies from ODI, including this one. So I'm going to hand over to you, Bassam. I'll move your slides, and when you get to 1 minute to speaking, I will start waving my hands around, so you'll be able to see me then. Thanks, Bassam. Over to you.
Yeah. Okay. Thanks, Fiona, and thanks for moving the slides for me. If we go directly to slide number 3. Yeah. As Fiona mentioned, Gaza has been... Gaza...
Wrong one. Wrong presentation. Sorry, hold on. This one?
I can't see it, yeah.
Methodology?
No, why Gaza? Why Shijaiya?
Is that before? Yes.
Is it?
Yeah. Yes, go ahead.
Yeah. So as Fiona mentioned, Gaza joined the project late, and after the war in 2004, it has been decided to include Gaza because Gaza reflects really compounded vulnerability, high unemployment rate, contextual difficulties, political problems, exposure to repetitive trauma, hardship cases. Like just to give an example, the unemployment rate in Gaza is higher than Rwanda. The number of CT beneficiaries benefiting from the cash transfer has increased by 250 times within 10 years, mostly due to contextual factor. Also, Gaza reflects a place that is subject to strict religious and cultural norms, which really put more pressure in girls. Next one, please. The methodology we used, it was really diverse. We used many tools. We started by doing mapping for the services available, and we benefited from the UNICEF database. Then we did the health facility assessment for 5 sites, including 2 sites for Ministry of Health and 3 for other NGOs. We did focus groups more than what anticipated, because we added two focus groups for people living in shelters, in shelters for people with displaced people. We noticed that it's difficult to do focus groups for people with serious mental illnesses, and we increased the number of IDIs to replace that, and this point is worth considering in similar research study. Next one talks about the key stressors adolescents in Gaza face during and after the war. At the top of the list was losing homes, being physically exposed to injury, losing a beloved family member, especially if that member is the breadwinner of the house, feeling unsafe, and living in 6 mixed, crowded shelters. And as a result of the war, people were displaced, and at the displacement center, there was lack of privacy, especially in using the toilet. People were found living with strangers, and this really came on top of chronic exposure to vulnerabilities, because the situation in Gaza after the war, it's acute, on top of a chronic, where we face chronic stressors like economic hardship, lack of recreational activities, violence, lack of electricity, fear of sexual harassment, overprotection for the girls, linking the family honor and family reputation to the girls' behavior. All these represented compounded vulnerability which affected the adolescent girls. The next slides illustrates the main coping strategies utilized by adolescents and their parents, staying at home because of the security fear, turning to religion and practicing prayer, especially by girls. Listening to radio, and listening to radio sometimes increase their exposure to stress because they hear bad news. Girls spend some time in doing housekeeping tasks while boys lift the houses and socialize with friends. Also, girls practice daydreaming, imagination, talking to aunts. Girls more than boys participated also in psychosocial activities at shelters and at schools. In addition to that, seeking traditional healers. And when the situation turns serious and physical symptoms appear, people approach the advanced psychosocial interventions or mental health programs. However, most girls' coping strategies were positive, like investment in education, while most boys' coping strategies were negative, like using tramadol and drop out from school and joining the labor force. The next slide shows how there was increase in the number of cases. One of the main NGOs in Gaza Community Mental Health, reported an increase by 90% of new cases, the difference between the year 2003 and 2004, which really reflects how the situation affected the mental health of the people and drives them to seek services. The next one also reflects how there is a gap and misunderstanding between parents and adolescents. Both of them don't understand each the other. Parents don't show any interest or respect or understanding to adolescents' needs, and also adolescents don't understand the concern of their parents. Next, please. The next shows the children playing in Gaza. Also, the picture shows the gender role and the cultural role, how adolescents. Next slide, please. The next slide, it's really describes the services. So we have the traditional providers for mental health who used to work before the year 2009, when the first war started in Gaza. In Gaza, we suffered from 3 wars in less than 5 years, 2009, 2012, and 2014. So the Ministry of Health is the main provider and supposed to be the main regulator of services, and it operates 6 community mental health specialized clinics beside a miserable hospital, and also it recently introduced the psychosocial services at its 54 centers. UNRWA started introducing the psychosocial services into its schools and the clinics and also social centers providing humanitarian aids. However, only around 2% of the Ministry of Health budget goes to mental health of the total budget, and mostly to the hospital, although the mental health services are the most expensive among all the other primary healthcare services when we did analysis 2 years ago. However, after 2009, there was a wave of providers providing psychosocial services, more than 160. Many of them, they have no any clue about psychosocial services. They provided the services just in response to the fund and to the request of donors. Next slide, please. During the conflict, strangely, most providers, they suspended their work, and the priorities was more towards physical needs on the price of psychosocial needs, and the interventions were provided were reactive rather than proactive. The 2010 mapping done by Terdizom shows that there are 3,100 different kind of activities, which really reflects the fragmentation of services. And many organizations really provided the services without being adequately prepared. Sometimes even they did harmful things when they sent unqualified and newly graduates team to the field who themselves they need psychosocial support. The services are short-term oriented. I looked at the UNICEF database in Gaza, and I found that there was around 60 psychosocial programs implementing in the Sijaiya neighborhood, alone. Although the mapping does not include all the providers, like Ministry of Health and UNRWA are not listed there. And these programs will ended by December, so it was ended within 4 months. Some organizations implemented up to 17 projects at the same time, which really reflects that, how they will manage that. And 16 organizations implemented the program serving between brackets 25,000 children. However, many of the children benefited from more than one organization. So these numbers are double counted, and not necessarily those are the most needy ones. The dangerous thing is that some international organizations engaged in direct provision of services, which is risky at the long term for sustainability. Next one, please. Mostly the implemented interventions was debriefing, awareness session, fun days, and it was more of first level interventions. And usually children and adolescents are, adolescents are overlooked. Very few programs targeted them, while children under 5 and women who are older were the focus of the program. Some training was provided, but it's fragmented. There was no strategy for that training. It ended that we don't have specialized people, and all the psychiatrists we have will retire this year, and this will leave the country without having any psychiatrist who is specialized. The access to psychosocial programs, it's okay. We have good coverage. However, people who are living close to the clinics or know the stuff are the ones who are mostly benefited. However, the quality is a problem. In terms of specialized services and mental health, both the coverage and the quality really are a problem. This one, I think we discussed about it, how the programs were reactive programs and how the school counseling is far from achieving its goals. Next slide, please. It really talks about the approach of providing the services. There is no strategic direction for providing psychosocial and mental health services in Palestine. Different providers use different modalities. Some use COPE, some use CABAC, some use randomized clinical trials. So there are people do shopping, and also service providers do shopping of these programs. And it does not reflect really diversity or having more options to the clients. Providers' division of tasks is unclear. The work is overlapping. There is no continuum of care. The client, it's like the ball of fire, and everyone wants to throw it to the other. In documentation, even some people use the ICD-10, some use DMS-4. So it really reflects how there are serious gaps in terms of service provision and also in terms of assessing the impact. Coordination is limited. Unfortunately, the Ministry of Health is more affiliated to its service provision role rather than its regulatory role. So it invests little in coordinating among providers. So instead of managing the services, it's being managed, and it hires more than 1,200 employees and do very little in coordination. The licensing system is very weak, it's fragile. Anyone can establish organization, anyone can rent a flat, hire some people and do the services. Referral is also in one way. Communication between the referring body and the referral sites it's almost not existing. Next, please. Most people are self-referred. Health providers only refer 20%. Teachers, sometimes they refer students with bad academic performance, and sometimes those who engage in relation with opposite sex. So it's more for disciplinary things. Providers are neither age nor gender sensitive, and we have some quotes already. Fiona mentioned some of these. The cultural mainstreaming affected how behaviors behaved and how they were judgmental when they treating or receiving the clients. Providers themselves, they are being stigmatized by the system itself and also by other people. One of the Director General mentioned to me that during the meeting, the Director General of Mental Health, people used to make fun about him. And he himself used to tell, see, all those Director Generals are crazy. I need to open files for them. So it's a mutual between the two sides. However, when we did a study for medical students, do you want to engage in mental health? Only 2%. Gaza University said yes. Most of them, they want to go to surgery. These slides show some of the quotations. The last slide, the psychosocial programs in Gaza are there, it's available, but there is poor coordination and regulation. Usually people are the ones who decide about the service. They are the ones who decide when to go, how to go, what to take. Existing services tend to be short-term oriented and reactive. We have very few number of specialists. Provider attitudes about age and gender contains or encounters serious gaps and needs to be urgently addressed. Services provided are neither adolescents nor gender sensitive and do not address the adolescent girls' multifaceted vulnerability. Thank you very much.
Thank you very much. Thanks very much, Bassam, and that was perfect timing. Well done. I'm going to move quickly on now to Janice. We already presented her before, but just briefly, she is the country representative for health and the project lead in Liberia Mental Health Initiative for the Carter Center. She is responsible for capacity building of the mental health program. A Liberian native, she has worked in the public, private and faith-based sectors in both health and mental health as a policymaker, researcher, and implementer in both Liberia and the US. And she has been our study partner in Liberia. So I will hand over to you, Janice, and you have 15 minutes.
Okay. And where am I pressing this to? Oh.
Anywhere.
Anywhere?
Yeah, anywhere.
You can just go forward.
That's not me, though.
No, that's not the right one.
That's not me. Yeah. That's it.
Yes, that's the one.
Okay. Okay. Thank you so much for having me. This presentation, I'm just representing a group of people that work in Liberia, including the Liberia Center for Outcomes Research and Mental Health, who are our partners in doing this. It's a local organization that's made up of the Ministry of Health, the JFK Medical Center, and the Carter Center in an attempt to grow research in Liberia. So I'll talk first of all about our two study sites. Bomi County, we are in Tudmanburg in Bomi County, where during the Civil War, it was a bastion for rebellion against the capital, and it saw at least 4 transfers of power, one in which the residents still talk about, where over 200 children died from starvation. The effects of EVD, Ebola virus disease, there has been that we lost 38 people, and there were 12 survivors, of whom we actually have spoken to 2 child survivors in our study. We are also in Nukru Town, which is in central Monrovia. And Nukru Town is, by all accounts, a slum. And it is heavily congested, and depending on who you talk to, there are between 70,000 people or 140,000 people. living there. During the Civil War, because it was so densely populated, it was a safe haven for many, many people, and many people who were part of the warring factions. Nukutown was heavily hit by Ebola virus disease. It has 163 survivors, and there were 120 deaths from Ebola. I just want to give you some context before I start talking a little bit about the service delivery and what's going on right now. First of all, as far as adolescent girls are concerned, nationally, about a third of girls between the ages of 15 to 19 have either have had a live pregnancy or have children. And Bomi is around the national average, and Montserrado, where Nukutown is located, is around 17% of girls. And this data is from 2014, the National Health Survey, but the data was collected. Data was collected in 2013. I also need to tell you, because this is a huge part of the framing in terms of gender and social norms, is that many young women and young men go through initiation in Liberia called the Sunday Society for Women and the Poro for Men. And it is initiation as adolescents into adulthood. And nationally, the age group from 15 to 19, about a third of young women asked said that they were a member of the Sunday, and initiation is female genital cutting or mutilation. In Bomi, that's very high. It's almost 70% of the women, and this data isn't disaggregated at the county level, I'm afraid. So in Bomi, for women and girls, about 70% have been through the Sunday, and in Montserrado, that's about 35%. So post-Ebola, talk a little bit about the context for adolescents in that regard. The government does have a adolescent and sexual reproductive health strategy, which already tells you where psychosocial sits as far as that's concerned. Mostly focused around adolescent reproductive health, and particular adolescent pregnancy. Very little reference to adolescent psychosocial or psychological well-being. A third of girls, as I've already said, have been pregnant or have a child. And then we have a very high level of sexual violence in our country, especially around children. And this data is from January to September of this year from the Ministry of Gender, Children, and Social Protection. And that you can see that of all the rapes, 11% were for children 6 to 9, 37% from 10 to 15, and 25% from 16 to 17 years old. Just to give you a little context in terms of how Ebola affected children, we don't have data disaggregated by age for children that were orphaned or lost one or both of their parents, but over 5,500, almost 5,500 children lost one or both of their parents. About half of those were girls. We have approximately 5 children that are receiving some kind of case management service as a result of Ebola. And we have an increase in the number of children who are in institutional care. That is not the preferable way for the government to handle children who are orphaned or separated from their families, but because of Ebola, that's been the case. So a couple of myths about Ebola and gender. Very early on, our Minister of Gender came out and said that women were disproportionately affected by Ebola. And everybody said, yeah, that makes sense, because they're the ones that are taking care of the family. They're the ones that are doing everything. Well, unfortunately, that was not true. It's about half and half, both among those people who have been infected as well as the survivors. And the other big myth is that because it's an infectious disease, sexual violence would decline. It did not. It remained the same, especially sexual violence against children. So this chart just really shows you, this was done earlier in the year, and it just shows you the numbers of gender-based violence cases, and then the number of rape cases separated from that. The first bar is from 2014, and the second bar is up until June of this year. And then the sad story of this is that close to 90% of the rapes are for children, and and most of the deaths, even this year's deaths, are for children. So post EVD, what are there any specific programmings? Fiona was really interested in me talking to specific programming for adolescent, not without our fair share of advocacy, but there's still no adolescent-specific programming around EVD. What programming that exists for EVD is more a charity model than an empowerment model. I, as part of the mental health and psychosocial pillar for the Ebola response, I was overseeing the Survivor Network, and they coined a phrase, "Don't scratch me where I don't itch. If I get another bucket, I'm going to hit somebody." So between buckets and mattresses was the bulk of what the psychosocial response was for EVD. And they're very, very cynical about the response. UNICEF provided one-time grant for children who were orphaned or affected, all children, of $150. There was a real delinking between development and planning, and still exists around EVD. Right now, we're struggling to spend all the EVD money before December because it goes back to where it came from. And so there's really not a real concerted effort around planning, let alone planning around adolescence. We have a concept in SGBV, sexual and gender-based violence, that's called a one-stop shop, where all services are located at one place. None of them are functional. I train the clinicians we train there, so at any one given time, we are there doing some kind of training, and it's just not working. Safe homes are not functional. Some of them have lost their funding from the government. Some of them get funding sporadically, and children, especially adolescents, girls, linger there. School-based mental health services are being proposed, but they don't exist right now. And probably the most could be successful, said to be a successful program is an initiative around employment of adolescent girls, but it doesn't have a mental health component. So there's a lot of discussion about whether we could do something around that. So quickly about that particular program is funded by the World Bank. It's a 6-month program to train adolescents between the ages of 16 and 27. It's had a significant impact on employment and their ability to earn, but no significant impact in Yucatan, which is one of our study areas. This is one of the only places where it has not had a big impact. And there's now an effort to try and add a psychological health component to the programming. So quickly, I'm not going to spend a lot of time on the INGOs and issues, because I've already talked a lot about this already, but the need to engage in a long-term strategy and that's really tries to move the needle on what I consider some fairly intractable problems. It's not really the glance or lens through which it's usually seen. So long-term issues around teen pregnancy, sexual violence, and the way that children are seen as property in general. And then we do have some local NGOs that are trying to work in this space, but they are inadequately funded and often don't have the necessary expertise. And when Bassam was talking, I just wanted to say, well, why wouldn't we just say ditto? You know, everything is the same. We're all the same. I have a miserable mental health hospital also, Bassam. It's pretty much the same. I wanted to end on a couple of things that I got an aha moment in a series of interviews we did with Christina Lamb earlier on in 2014, when girl after girl and mother after mother talked about the opportunity that came that led to their child being raped. So this is Blessing. You can see her back here. She's 4 years old. And this is her mom, Bindu. And Christina asked, can you tell me what happened to you? And Bindu said, it was 2010 when I was on the farm with my little girl. Then a young man came to us, so I decided to go back to the village to get some rice. Then that was when I left my little girl with him on the farm. Upon returning to the farm with rice, I noticed that my little daughter was crying. I tried checking to see what was causing her to cry. When I took off her diapers, I noticed blood all over the diapers. Then I asked, what have you done to my child? But he could not say a word. So I went and reported the incident to the police in Tudmanburg, Bomi County. The police arrested the boy, put him in prison, and sent us to the hospital where my daughter was admitted. And so Christina asked, "How old was your child?" By then, she was just 4 months old. And then Christina asked, "What happened to the young man?" At first, he was put in prison, but he was later let free by the police because according to them, he was underage. But I knew that he was not underage. So then Christina asked, "How long did you leave the boy with your daughter?" And she said, "About 20 minutes. So that made me realize that and other incidents that were recorded to us, the intersection between development and adolescent health and well-being, and child health and well-being, and the reduction of the kind of violence towards children. So I've already talked a little bit about this, so I won't spend more time on it. All the girls that we talked to prioritized education. This was how they saw themselves getting out of the situation that they found themselves in. And families also prioritize education to the extent that unwittingly they put their children in harm's way. They send their children to live with more well-off people, and those more well-off people abuse them in so many ways. So Fiona asked me to say something about services and how effective services have been. And so I decided to take some quotes from one of our study subjects, and this is JK. JK lives in Bomi. She was referred to us to be in our study by her mental health clinician, who is Meti, and JK is a survivor of EVD. She and her sister are the only people left in her immediate family from EVD. So JK says, talks about how sometimes I sit down and I just cry. But at least I'm moving on small, because I can go for counseling sessions and they are teaching me how to cope with my situation. So I just have to accept it the way it is. Before the counseling, I was looking like a crazy woman. I was getting crazy self. I was getting crazy that how Auntie Meti just be going for counseling session. We used to go every Thursday and Friday, so at least now I'm all right small. And then this is another place where JK talks about her relationship with her Auntie Meti. Auntie Meti can console us, so we go for consoling classes. Me and my sister, the time they took me from the ETU, that day Auntie Meti came, carried us home. Me and her took picture together and everything. And then JK talks about, we ask her, when did you know this Auntie Meti? Only during the Ebola crisis we knew Auntie Meti. But she acts as if she's our ma self. She can behave just like our ma, because anything we lack, we explain it to her and she can help us. Even self, when something bothering us, we explain it to her, she can find the solution. And then this final one, which really touched me. I hate one thing about myself. I can just sit down by myself, get vexed, which means angry, by myself, and I know what thing that make me vex. And that other behavior, and I like it. I try to leave it. So the understanding that all that she's experiencing gives her this anger that she has to resolve is what she's trying to explain to us. So thank you very much.
Thanks very much, Janice. A bit of a tough picture coming from Liberia, but yes, acknowledge that ditto as in Gaza. But hopefully there is some positive stories also coming out of there. So now I'm going to move, but great timing, thank you. Now I'm going to move rapidly on to Haja, who, as we heard before, is a health system researcher based at the College of Medicine and Applied Health Science in the University of Sierra Leone, and she's part of the broader Rebuild Coalition research consortium. She's done significant work on health worker experiences in the context of a crisis. And she's focused on gender, community engagement, health system strengthening, amongst other things. So I'll hand over to you, Haja.
Thank you, Fiona. So I'm going to be coming in from a slightly different angle. I'm going to be talking about female health worker experiences of crisis, so conflict as in the Civil War and Ebola in Sierra Leone. So as mentioned, I work for the Rebuild Project, which we work in post-conflict countries to generate evidence to inform the policy-making process. And one of our projects in Sierra Leone was focusing on human resource for health and trying to find out what are the effects of conflict and crisis on the health workforce. So the research aim was to understand the post-crisis, so post-conflict, post-Ebola dynamics of health workers, and to understand what were the gender dynamics in that process. Analysis was done through a gender lens to try and explore what were the challenges to resources, the different roles, the value, the decision-making process, and power relations during the crisis. The research itself was guided by a number of questions, including what were the gender differences in the experiences of these health workers, how were gender considerations integrated into the rebuilding phase in the post-conflict period, and also what impacts did the rebuilding of the health systems have on gender equity within the health sector as a whole. We were also mindful that doing that type of research, there are threats and opportunities. So the opportunity being that the findings can help shape or reshape the roles and responsibilities as it will highlight the gaps and the challenges in the health system, the health for health workers in general. And then the threat is that we were mindful that there are existing pressures on available resources and systems already in a post-conflict situation. So that might undermine gender balance and might result in gender not being seen as important, being put on the shelf. So therefore, any strategies to try and bring about responsive human resource for health might not be seen as important. So in terms of research methodology, we conducted in-depth interviews with 23 health workers working in the public sector. So we spoke to them before the Ebola outbreak to capture what were the challenges for them after the conflict, and then with the Ebola, during the Ebola outbreak, we went back to a number of them and asked what were the challenges during the outbreak itself. And then we also conducted a health worker incentive survey to see how are there any differences and what impact is financial incentives having on health workers in general. So the study districts that we selected were, just to give a representation of north, south, east, and west. So Koinodugu was in the north, Kenema in the east, western area in the west, and Bonth in the south. And two of them, Koinodugu and Bonth, they're particularly hard-to-reach areas. And Kenema happened to be one of the districts that was severely hit by the Ebola outbreak, and so was the western area. But then the other two, Koinodugu and Bonth, again, because of the remoteness, I think that helped with the crisis itself, that the number of cases that they reported was not as severe compared to the other two districts. So we tried to answer what makes up gender power relations in this context. So I'm not going to go through all of that, but just to pick up on some key points. So with regards to who has what in terms of access to resources, so that's information, education, skills, income, we saw there were different patterns of employment. If you compare male and female health workers, there was difference in access to pre-service and in-service training. A lot of the in-service training was geared towards male health workers, and female health workers were only given opportunities to go for short courses because they have other roles to play within the house as well, so they cannot go off for long. And in terms of incomes, there were differential incomes if you compare male and female. And then who does what in terms of division of labor? There are specific cadres within the health sector where it's predominantly female. So like for instance, the MCH aides, maternal and child health aides, and TBAs, and then you have a group of women, because we're having this transition now from TBAs to CBMs, community-based monitors and motivators. And they basically, their role within the communities is to try and motivate women to seek health services from the health facilities as opposed to going the traditional route. So a number of cadres within the health sector were predominantly female. And then women have to juggle being housewives, looking after the home, and also being productive in the workplace. And then how are these values defined in terms of social norms, ideologies, beliefs, and perceptions? Different factors were captured, underlying motivation in the workplace, comparing male and female, their career choices. A lot of the female nurses, for instance, when asked, why did you want to become a health worker? It was one of those things, because being a nurse is seen as a female job in Sierra Leone. So it's one of those things where a lot of them said, oh, because my uncle or my father, so an influential male person in their life, influenced them to become a nurse. Because at that time, maybe the education itself was free, so they were pushed into doing that. And in terms of who decides, so rules and decision-making, both formal and informal. So again, career choices was captured in that, their experiences of management, and also coping strategies was very different, as I mentioned earlier, and I'll go into that a little bit more detail for male and female when faced with a crisis. So this just shows some existing data on the gender differences. So with regards to, as I mentioned earlier, some cadres within the health sector are predominantly female. So if you look at the SCCHN, which are state-enrolled community health nurses, and then the MCHAs, they're predominantly female. So these are a group of health workers who work within the communities. And then if you look, I'm not sure if it's very clear, but if you look like the higher cadres, doctors, and so on, you have a lot more male health workers within that group. And with regards to income, for the same job, a female health worker would receive less salary compared to a male health worker, and that's shown in the table there. For instance, a male doctor will receive 4.7 million leones every month, and a female doctor will receive around about 3 million. So there's this difference between what they take home at the end of it. So looking at the effect of conflict, so this is the war itself on female health workers. So health workers in general, after the conflict, they became targets. They were victims of conflict. They were prime targets to be kidnapped by the rebels because they were expected to provide medical services behind enemy lines. And then if a female health worker was unfortunate to be kidnapped by the rebels, then they're further exposed to sexual violence behind enemy lines. And then others who were not kidnapped, they reported having to face additional social and economic challenges. Because if the male head of household is no longer there, they have to take up that role. And how did they cope? Religion. Religion was captured across the board. A lot of them used religion as a coping strategy. And others avoided wearing their uniform so they're not identified as being a health worker. And that was interesting because one of the motivating factors that motivated most of these women to become health workers, to become nurses, was the uniform. They saw it as a sense of pride. But then during the conflict, they could not put that on because it meant that they could be easily identified. And then, so still in the post-conflict, how were gender considerations integrated within the rebuilding of the health sector after the conflict? So a number of strategies were proposed, a number of documents were produced, one of them being the National Health Strategic Plan. And its stated goal was to reduce inequalities and improve the health of the people, especially mothers and children, through strengthening national health systems to enhance health-related outcomes and impact indicators. However, as somebody from Sierra Leone mentioned this morning, a lot of these policies in Sierra Leone stay on paper. It was not implemented effectively. And then another document was the WHO country cooperation strategy, which makes reference to gender mainstreaming and with an aim of reducing infant and child mortality and promotion of reproductive and sexual health. However, if you go through the document, there was no specific implementation plan as to how to address these issues, these gender mainstreaming points. Apart from, it was just mentioned that they will work with the UN Gender Theme Group to support the implementation, but that was it. So now, if we look at Ebola, the effect of Ebola on female health workers. So in general, effect of Ebola on female, on women, women were more vulnerable to the Ebola due to their caring roles. I think that's slightly different to what was captured in Liberia, because what we saw in Sierra Leone, looking at the overall picture, approximately 57% of those who died from Ebola were women, compared to 43%. And that was reported in the multi-sector impact assessment of gender dimensions of the Ebola virus in Sierra Leone. And then, as I mentioned earlier, women predominate amongst the lowest cadres of health workers who work within the communities. And they were very important during the Ebola outbreak, because then they can work within the communities. They can talk to the service users and dispel a number of myths that were going around as to how the virus itself was being transmitted, and try to get them to come back to use the health services. So we saw, so that role was positive, but then it exposed them to being, there's this exposure to the virus, because they were constantly out in the communities. But then if you look at the health workers, this was published this year, looking at the number of health workers who died from May to December last year. That was at the peak of the outbreak itself, so disaggregated by gender and also the age. A lot more men died from the virus compared to female health workers. And one might argue that for the men, it captures even the non-skilled health workers, so the burial team, the ambulance drivers, and they were all male. And then with the female, they were providing care within their roles within the health sector. So even though there's this slight difference in the numbers, you might argue that, well, a lot of the male health workers who died were not skilled health workers. So how did the female health workers cope during the Ebola outbreak? Again, religion came out, and peer support, where they look out for they look out for each other. So they become everybody's, when you're working, a female health worker will look out for the other female health worker, and they encourage one another. There was one respondent who mentioned that they use social media. At the end of every shift, they will go home, they have a group on WhatsApp and send a message just to check that everybody was okay. How are you feeling? Are you feeling X, Y, and Z? If you feel this way, maybe you should go and get yourself checked. And then there was another respondent who was forbidden to go to work by her partner and have children, because they were afraid that she'll contract the virus. And what she had to do was to lie. Every day when she was going to work, she would say she's going somewhere else to go to work. But overall, this highlighted that there was a lack of a structured psychosocial support system for these health workers, because they had to find other ways to deal with what they were, the stress and what they were having to deal with every day. And then if you look at the effects of Ebola at the community level, so there was a reduction in service utilization, looking at maternal health, for instance. There was a reduction in women going to the health facilities for institutional deliveries. So that resulted in an increase in maternal deaths. And something else that was quite interesting that came out, a number of community health workers were used during the outbreak to go into the communities, because they are usually from within the community, so they know who is pregnant within their community, to try and get women to go to the health facilities. And what a number of these women will say, that I cannot make that decision, come back when my husband is home, and he will tell me whether or not I should go to the health facility. And another unintended effect of the Ebola outbreak was that we saw an increase in teenage pregnancies, and a number of these teenagers were Ebola orphans, who parents were no longer there. People were not willing to take them in, so they had to engage in sexual activity as a means of survival. So now the post-Ebola recovery plan, that would have been an ideal opportunity to integrate a number of these issues into the rebuilding stage. But however, it seems like that opportunity has been missed, because if you look at the document itself, there's not a single mention of the word gender in the document itself. And a report has been generated by another ministry, the Ministry of Social Welfare, which highlights that gender should be important in the rebuilding stage. But then we have this challenge where in Sierra Leone, where different ministries, they don't have an active communication channel. So this report that's been produced by the Ministry of Social Welfare has not been acknowledged by the Ministry of Health and has not been used to inform the rebuilding stage of the health sector as a whole. And I mentioned earlier this morning about the Survivor's Dream Project, which is looking at female EVD survivors. So 20 women, 12 months, and they're given skills to empower them to integrate back into society and to ensure that the program itself is sustainable. Because once you're trained, the idea is you go back and you train more people within your community to ensure that the program itself is sustainable. Thank you. So that's just a picture of the female survivors. And one of the empowerment sessions that they had to do was a makeover session. So that's why they're all looking very colourful.
Thank you. Thanks very much, Heather. That was very interesting to hear a sort of complementary perspective from Sierra Leone, focusing on health workers and gender, but also the psychosocial dimension is sort of coming out there as well, and also hearing how it complements to Liberia. I'm going to open the floor now to questions from you all. I have also here Saji and Diane, so in case there were questions left over from the first panel, they would be here to respond to them and obviously to any other questions. And I will also be taking online questions. So are there any questions in the audience?